Hello, I'm West Virginia Superintendent of Schools, Michelle Blatt, and I'm excited to welcome you to this interactive virtual healthcare experience, Imagine You. Imagine You is a partnership between the West Virginia Department of Education and Charleston Area Medical Center that virtually transports you from the classroom to the operating room. The technology and resources available provide you with an experience like no other. You will no doubt be shaped by this amazing medical procedure. As we all know, healthcare workers are critical members of our community. Imagine You encourages students like yourself to pursue careers in the healthcare industry. The Mountain State needs adept professionals who are dedicated and passionate. Participating in Imagine You is an early step towards your future as a healthcare specialist. Following the procedure, you are encouraged to tweet or email any questions you may have to the surgeon. Take this opportunity to stay engaged throughout the process and gain a better understanding of the medical field. On behalf of the West Virginia Board of Education and the West Virginia Department of Education, I hope that you find this experience insightful and beneficial. Make the most of this opportunity as you move forward to your success. Thank you.
Hello and welcome to Imagine You, a virtual healthcare experience. During this webcast, you'll take a virtual step into the operating room to see a surgery being performed at CAMC. In addition to learning about the procedure, you'll get to see how healthcare professionals are using their knowledge and skills to improve patient care. The healthcare field is always growing and expanding. At this point in your education, you're probably considering what your career choice may be. We hope this presentation helps you see how you might fit into one of the various roles of providing patient care. In recent years, government regulations has limited students' access to job shadowing and viewing procedures. This virtual healthcare experience is an innovative way for you to see surgery while still protecting the privacy of our patients. We're very excited to bring you this program and look forward to your feedback. Thank you for spending your time with us today.
My name is Adam Purdy. I am the Respiratory Care Manager at Women's and Children's CAMC Division. I've been with CAMC for 9 years. It'll be 10 years this January. I've always worked in respiratory therapy. I started out as an extern through school, which helped me get a head start into my professional development. What I like most about my job is just being very involved at Women's and Children's. We have a close relationship with our nurses and our physicians, and we spend a lot of time at the bedside, and that's really important for me because we have a high expectation of respiratory therapists at our hospital. We manage nebulizer therapy, oxygen therapy. We have patients on the ventilator, patients on CPAP. We perform blood gas analysis. We run a blood gas lab. We also manage specialty gases such as nitric oxide and heliox. We have a blood gas lab where we perform and analyze arterial, venous, and capillary blood gases. What's nice about having a blood gas lab within my department is we're at the bedside with our patient that might be on a ventilator. We attain a blood gas to manage their settings and to see their outcome. We can directly take it to our lab, run it on our instruments, have the result, and physically hand it to our physicians. Once we do that, we can make recommendations to our physicians for changes or to see how we want to approach our patient. I would recommend taking human anatomy or anything chemistry-based when pertaining to respiratory care. So with respiratory therapy, you can attain a 2-year associate's degree or a 4-year bachelor's degree. Once you have that degree, you must take a credentialing exam to the National Board of Respiratory Care, and you can either become certified or become registered. And once you do that, you will attain your license through the West Virginia State Board of Respiratory Care, and then you can practice within our state. Respiratory therapy is a great career and it's a great profession. You get to interact with physicians and nurses on a daily basis. It's very satisfying when you see a patient come in and at their worst moment, and you're directly taking care of them, and you're providing care to them, and which results in a good outcome. And these patients get discharged home, and it's very satisfying knowing that you made a direct impact to their care.
My name's MJ Stein. I am a registered nurse case manager. I have been in this role for about 6 months, but I have been the care transition coach for almost 5 years at CAMC, and I've actually been a registered nurse for 33 years. What I like about being a case manager is that you really have to work hard to try to get help for people, and everyone has different needs, everyone has different goals, they have different perspectives, they live anywhere all over West Virginia in different areas of the country too, and come to us. And it's a very busy job, but it's very rewarding because there is chance for advancement and to become certified as a case manager, and that includes the social workers also becoming a certified case manager. I have worked for CAMC on and off for 33 years. I started as a nurse extern on 3 West at Memorial. When I graduated, I worked in CVICU, which is now Open Heart Recovery. That's how long ago it's been. I also worked in surgery at Women and Children's, worked in different insurance companies. So I had a lot of experience coming back as a case manager, care transition coach. I was able to pretty much just jump right into the job, work with placements for patients such as skilled nursing facilities, inpatient rehab, long-term acute care hospitals, and those types of things, as well as getting home health for patients, as well as durable medical equipment like oxygen and CPAP machines and BiPAP machines. It's very important because a high percentage of the multi-visit patients are actually financially about 60 or 70% of the total cost for hospital patients. In other words, they make up the major cause of most of the costs that are incurred by patients at the hospital. So, we want to reduce readmissions of course, for the patient's sake, because the patient, ultimately is the one who has to go home, take care of themselves, and become independent if possible. And if we don't get those things in place, like the home health or the skilled nursing, those types of things, those also can add to the length of stays at the hospital, because also if the patient does not get everything that they need before they go home or go out of here, they will readmit. So we try to work to reduce those barriers that make the patient, less likely to readmit to the hospital and have a successful, independence at home or wherever they may be. There's a chance for becoming a certified case manager, and that's for the social workers and case managers. And it's like a 6% raise, so they become a certified case manager. Which gives them a better knowledge base as far as knowing how to take care of these types of patients. And as a matter of fact, there's growth for becoming a manager. I became a manager just in April. So there's definitely opportunities for, to get into management if you want, or to be certified as a case manager. The most favorite part of my job is getting satisfaction from helping people that truly want to be helped. I had a situation with a patient who was very depressed, kept readmitting. She was one of our readmission multi-visit patients. Once we got to the root of what the problem was, part of it was housing. She was turned down for housing due to criminal history, but I was able to write a letter and get her housing, and I actually got the Heart and Soul Award for that. That was very satisfying, not just for me, but because just to see the joy in her face that she was able to get housing and that she was going to be independent, and that people cared for her. That's the bottom line. She just felt that we cared for her, and she was very appreciative of that.
My name is Jason Hundley. I'm a certified medical assistant level 2. So you need a medical assistant diploma or certificate. Myself, I went to Everest University. It was a 9-month course. Usually it is 12 to 14 months long, but theirs was condensed into a 9-month period. I went every day after work, 5 days a week, and it was a 5-hour day. So they crammed it all in together. I've been here for 13 years. I did my externship straight out of Everest at the oncology center, the cancer center, and I got employed my very last day on the job. My job duties on a daily basis are anywhere from clerical to clinical, patient assistance, phlebotomy, patient triage, getting the patients ready to see the doctors for their appointments, FMLA paperwork, just assisting the nurses and doctors one-on-one. Growth opportunity for a medical assistant usually would go from a medical assistant to an RN or a registered nurse. CAMC offers an RN tuition program where, as a CAMC employee, they will pay up to $5,000 per semester for nursing school. There are certain criteria that you have to meet. You have to hold a certain GPA, and upon completion, you have to work with CAMC for 3 years following. I have lots of favorite parts of my job, being that with the employees that I work with, they are all great, have the biggest hearts and willingness to help out our patients. But more so working one-on-one with our patients. Where I'm in oncology, it is very depressing for the patients. So just to be able to be a bright spot in their day and love on them and give them the support that they're looking for really, really touches my heart.
Hello, I'm Dale Witt from Charleston Area Medical Center. Welcome to our Imagine You webcast. You just watched a few people talking about their healthcare careers, and during our time today, we want you to imagine yourself working in healthcare. We have more than 3,000 students, teachers from about 91 schools across West Virginia who are participating today, and we appreciate all of you for joining us. Remember, anytime during their live webcast, you can email us your questions to healthinfocenter@camc.org, or you can tweet your questions to CAMC Health and use the hashtag ImagineU. Please include your school's name in the tweet or the email subject line. And don't forget, after the webcast is done, please fill out the online survey. It's at the same website you're on now, camcinstitute.org/ImagineU. Right now, I'm pleased to introduce to you Dr. Ghulam Abbas. Dr. Abbas joined CAMC Thoracic Surgery earlier this year and is the Cancer Services Director for CAMC and the South Region for Vandalia Health. Dr. Abbas, welcome, and thank you for allowing us to record the video, the procedure, and for joining us today.
Thank you very much.
So let's begin by just telling the students a little bit about what type of education you need to become a doctor, and talk about your residency and fellowships to become a thoracic surgeon.
Yeah, so Dale, I think healthcare is one of the best profession one can choose. To become a thoracic surgeon, you have to go through the medical school. Once you graduate, then you have to go for a residency program, which can be a general surgery residency followed by a thoracic surgery fellowship, or it can be an integrated thoracic surgery fellowship or training. And that leads to thoracic surgery completion of training. Then you have to take your board and be board certified in cardiac and thoracic surgery.
So you had 4 years of college, 4 years of medical school.
Yes.
And then how long did the residency take and the fellowship take?
The total time is 7 years, but I did an extra year of advanced fellowship in minimally invasive thoracic surgery, so it was 8 years for me.
Okay. So tell everybody, what is thoracic surgery?
So used to be historically, it's called cardiothoracic, that you do cardiac surgery and thoracic. The thoracic surgery means any surgery in the chest. Thorax in medical terminology means chest. So any surgery which will include lung surgery, esophageal surgery, And if you're doing cardiac surgery, it will involve anything related to cardiac and vascular.
Okay. We're going to show the video here in just a few minutes, and I'll go ahead and warn everyone now that if you have a weak stomach, you will see some graphic details of the surgery. It's an actual surgery, and some of it is a little bit graphic. First, we have a slide that we want to show the students and everyone about esophageal cancer. And tell us just a little bit about what it is, Dr. Abbas.
So esophagus is the food pipe which connects the pharynx to the stomach. It runs from the neck, through the chest, through the diaphragm, into the abdomen, and connects to the stomach. It's almost like 25 centimeter long and 1.5 to 2 centimeter wide. So the food passes through that and leads to the stomach. The esophagus contracts, we call it peristalsis, so it pushes the food down and gravity helps the food go down. There's a valve at the junction of the esophagus and the stomach, which is a muscle, basically a sphincter we call, to prevent reflux. And then we seen a 500% increase in the incidence of esophageal cancer in the last 30 to 35 years. It used to be more related to smoking and being the upper part of the esophagus. Now 85% of esophageal cancer happens at the junction of the esophagus and the stomach, and we think that's more related to reflux and our dietary habits.
Okay, so the surgery that we're going to see today, are you going to be operating near where the stomach and the esophagus meet?
Yeah, so you remove 2/3 of the esophagus and 1/3 of the stomach because you want to have enough margins for the cancer. And then you make a tube out of stomach to connect it to the esophagus. So basically you're creating a new esophagus using the stomach.
Okay.
And we call that conduit. When I use the term conduit, mean that you're using something, either a stomach or colon or a small bowel, to replace the part of the esophagus and the stomach you removed.
Okay. So you make sure you cut away enough to get all of the cancer.
Yeah, and the lymph nodes.
And the lymph nodes, and then you're reattaching.
Yeah.
Okay.
Simple plumbing.
Yeah. Very good. Remember, we want to hear from you during our webcast, so send us your questions at healthinfocenter@camc.org by email, and put your school name in the subject line, or you can tweet us at CAMC Health and use the hashtag ImagineU. So we're going to start the video now, and as we do, remember there are going to be parts that are a little bit more graphic than others if you have a weak stomach. So doctor, who helps you prep the patients?
So the operation is conducted by a team. So you have a scrub tech, you have an assistant, and you have the anesthesia team, and you have a circulating nurse. So the two teams, three portion I will say, is one team is the anesthesia, second team is the surgeon as assistant, third team is the scrub tech and the circulating nurse.
Okay.
So you basically need these three teams to work together as a team to conduct these complex operations.
And so right now you're making incisions for the instruments.
Yeah, this is the chest part of the operation. And you see my first assist, and you see the outstanding OR team helping us.
Okay, so you put the instruments into the patient, so you have a light, a camera.
So this is called ports. So
Yeah.
these are the 4 small ports you connect, you put through between the ribs into the patient or into the abdomen or whatever cavity you are operating, and then you connect the robot arms, and one of those arms you put a camera in, the other 3 arms will have the instrument. At a given time, 2 of the arms can work simultaneously. The third arm has to be stationary, and the camera, you can move it anytime you need to.
Okay. And now we see you sitting in a corner of the operating room controlling those arms. So you're still doing the surgery with the assistance of the robot.
The robot is not a true robot. By definition, the robot means a machine which will do independent activity. This is more of a master and a slave model where the robot is mimicking your finger movements. So it's a telemanipulator rather than a true robot.
Right, right. And so this is a laparoscopic procedure.
No, this is the abdominal part of the robotic procedure. So esophagectomy, we operate in the abdomen and then we go into the chest to remove the remaining esophagus.
Okay.
So we start in the abdomen and go into the chest. This is the abdominal part.
And this is the view, for the students watching, this is the view that the surgeon sees when he's at the console operating the robot.
So this gentleman had esophageal cancer, and it was a huge cancer and was deemed unresectable initially. So he was given chemotherapy and radiation therapy, brought for resection, and we could not resect it because it was attached everywhere. We sent him back and he got immunotherapy. Now you see a lot of scarring. You can see the instrument slipping. Normally the human tissue is soft, but you can see how the harmonic scalpel is slipping. The view you're seeing, you look standing in the abdomen and you're looking at the diaphragm, like you're looking through the roof of the abdomen. So on your left hand, you see the liver, the caudate lobe of the liver and the left lobe of the liver, which the retractor is lifting. What I'm dissecting is the cruise of the diaphragm, the entrance of the diaphragm, which once you cross that cruise, you're in the chest. So we're operating in the abdomen, going toward the chest, and that's the esophagus I'm trying to move and lift up. And you see the inflammation, you see the scarring. The instrument I have, which says harmonic, is an instrument which coagulates and cuts. It's used the ultrasonic technology, and it cuts the tissue and also make sure that the small blood vessels don't bleed. So it coagulates the blood vessels.
Okay, so we see the esophagus in the middle.
Yeah.
And you're shoving it to the side while you cut around.
Yeah, so I'm pushing the cruise away and the esophagus is right in the center. I just pull down on it. I'm lifting the attachment. So the goal is to circumferentially clear the esophagus, take all these attachments. Normally they are not attached to the esophagus. You don't have to cut through them, but this is after chemotherapy, radiation therapy, and immunotherapy. The cancer, body creates a reaction and a scar is formed. It's a thick scar which is formed around the esophagus. Now my arm is coming, lifting up the esophagus, and that at the base you see the left and right cruise of that's the left cruise of the diaphragm I'm cleaning up. Right under the left cruise of the diaphragm is the aorta, which comes from the chest into the abdomen. Now we're looking into the part of the chest which is called mediastinum, and we're cutting these thick scars around the esophagus. So you see the esophagus in the center. Now we're in the phase of creating the conduit. So we're going to make a tube out of the stomach. So we have to cut 3 blood supply lines of the stomach and leave 1 intact. So this is the left gastric artery. It's coming out of the celiac axis, which comes out of the aorta. So when the aorta comes in the abdomen, now you're looking at the pancreas right under my harmonic scalpel. So I'm lifting all the soft tissue above the pancreas to include in my specimen, because all the lymphatic tissue lies there and I want to make sure I take all the lymph nodes out.
A quick question from Mann High School. Was this patient a smoker?
No, he was a smoker, but the esophageal cancer at the junction of the esophagus and stomach is not related to smoking, is more related to reflux. I mean, the smoking does play a role, but that's not the sole culprit, as it's in the lung cancer. This is more diet, habit, obesity, and genetics. So we bringing a stapler. These are surgical staplers. They use a stainless steel stapler like you use in your stationery. And there's 3 rows of staples being fired on each side, and there's a knife in between to cut it. So rather than manually suturing and cutting, the staple is an automatic device. Now this is the stomach we just lift. And as I said, we cut 3 blood supply lines of the stomach and we're saving 1 artery, which runs along the greater curvature of the stomach. And this is the omentum, the fatty tissue in the belly. We're taking that to wrap around anastomosis up in the chest. So we're taking some extra omentum to create that omental flap, we call it. So that's still you're seeing the stomach. We disconnecting the attachments of the stomach in the abdomen. Just under my right hand or my assistant's right hand, you see the colon. So we're separating the stomach from the colon. And this is the spleen you're looking at, the top right corner right now. Is on the left side of the body. So this is the spleen. We're just cutting the attachment of the stomach from the spleen. Now, as this is the stomach, we're going to create the conduit, as I said. So we're going to cut the stomach into a tube to take it up in the chest. So these are, again, robotic stapler coming in. That's the first bite to control the blood vessels, to prevent bleeding. And now I'm going to make a tube out of this stomach to create a new esophagus.
And the staples will stay inside.
Yeah, the staples are there. They're non-absorbable. They stay for the rest of the life.
Okay.
But that's suturing. So they're cutting and suturing. So you can see I'm trying to create a narrow 4 centimeter probably conduit, a tube. So you'll see this is converting into a tube. So the stomach is like a bag and you're converting this into a tube to use it as esophagus.
What were the patient's symptoms that caused him to need this?
He's a young gentleman, 42 or 43, who came in with, could not eat solid food. Every time he could eat, it was causing difficulty from that cancer. And then he also lost quite a bit of weight. So now I'm attaching the gastric tube, the conduit, to the specimen side. So when I go into the chest, I pull that esophagus out, and this will bring this conduit, the new tube we just created. So I'm putting 2 stitches to make sure that the stitches don't break when I pull on this from the chest side. And I'm attaching the fat, the omentum, so it can come up into the chest. And after I do the anastomosis, meaning connecting the stomach to the esophagus, I will wrap that to help healing. So now I'm pushing the specimen part and the gastric conduit through the hiatus into the chest. And this is just a stitch to narrow it so the other organs like colon don't migrate into the chest. So we're narrowing the hiatus. Hiatus is the name of the defect in the diaphragm through which the esophagus passed from the chest into the abdomen. Now these are the ports for the chest part.
Are these separate from the ones that you already did?
Yeah, in the abdomen. No, initially when we showed, those were the ports.
Okay.
So this is the lung now. And we, on the left, what you're seeing is the backbone, the spine. And on the right is the heart beating and the lung is being retracted. Again, you're seeing a lot of thick scarring. So you have to separate this esophagus from the windpipe, from the trachea and the bronchus and the aorta. And the robotic surgery allows you to do precise dissection, because if you're 1 millimeter off from the plane, you can get into the aorta, you can get into the windpipe. This is a lymph node we're removing, and you see the windpipe right there. The tip of the suction is on the windpipe, the bronchus, the right bronchus, and we're removing this lymph node to send it for pathology to make sure that's not involved with the cancer. And with the suction is pointing, that's the trachea, back of the trachea, and you see it's dividing into left and right bronchus, or left and right windpipe. And then we continue to work on the esophagus, going up into the chest. This is the back of the esophagus. You see the aorta pulsating behind it, and you see the spine, the backbone, that the vein you're seeing is the zygous vein. So that's the esophagus. You see, we continue to separate it. That's the only attachment left now. So now the esophagus is completely freed. And that's the zygous vein you see crossing over to open into the, and you see the aorta pulsating behind it.
Yeah.
No, we're cutting the esophagus at the junction of the top 1/3, actually probably 1/4 and the 3/4. So we just, because the cancer was right at the junction of the esophagus and the stomach, so it's safe. We have at least 15 to 20 centimeter of esophagus being removed. And we leave almost probably 7 centimeter of the esophagus left in place. So now this is the esophageal stump, and we're using a technology called Orwell, is a staple anastomosis. So you see, I'm making a hole to pull a tube out. On the other end of the tube is the part of the staple connected. So this is coming out. It was introduced through the mouth of the patient. And I'm cutting that suture to pull that out. So this is the part we call anvil of this staple. This is a, so before where the staples you saw was the linear stapler, and the kids who will become biomedical engineers, they will be working on these instruments to create these staplers. So this is the anvil. This is a circular stapler we're going to use. So the one we used was a linear stapler. This is a circular stapler. It has two parts, anvil and the handle. So this is the anvil.
So it's this replacing that portion of the esophagus?
Yeah, so the esophagus we cut and we removed that specimen. Now we're going to pull, so this is all specimen, this is all cancerous part. So as we're pulling now, and that's this gastric tube is coming up from the abdomen. You see the staple line? This is our conduit, which I'm holding right now. So I cut this stitch and then remove this specimen completely. That's just, I'm securing it to the chest wall to create a hole in the gastric conduit or our new esophagus so we can put the handle of this staple through it. What you're looking is the ribs from inside and the chest wall, and so this is, we're just trying to make a hole in the gastric conduit, which is the gastric tube we created, so we can put you will see in a few moments that there's a handle of this stapler which goes into the gastric conduit. So this is the circular stapler handle going into that gastric tube, and there will be a pin coming out on the other side. So we advance it, and now you see there's a pin comes out, and that pin goes and locks into the anvil. And then when you fire it, it takes the part of the wall of the stomach and esophagus and suture them automatically, staple them together. And that's called the anastomosis. So right now you see the both ends are coming together as I screw this stapler. And as we're screwing this stapler, they come close, and then you fire this stapler. So it cuts, now they're connected. So when I cut through it, it just cuts the wall between the two organs and creates a hole. Now we're coming back with the linear stapler to remove the redundant part of the stomach. So this is extra stomach which we didn't need. So that's the new esophagus now. You saw that esophagus with cancer we removed. Now the fat pad we brought, omentum, we're just covering an anastomosis because 5% of time this anastomosis does not heal and it leaks. In that case, what the omentum does, it keeps it contains and let it heal faster.
So the pieces that you put in there, they'll stay inside the esophagus.
No, the staplers were removed.
Stapler was removed.
Yeah.
The interlocking pieces?
They're all removed.
Okay,
So
everything's
the
removed.
purpose of the foreign body was to create a common chamber.
Okay.
So to cut the wall between the esophagus and stomach to create an anastomosis. So there's a tube, there's a continuity now. So the food goes from the esophagus, which exists, into the new esophagus, which we created from a gastric tube. This is just to close it from the top. And we leave a drain in case there's a leak or a problem, so the drain will drain it. And usually you leave these patients in the hospital for 5 days, then you get a barium test on day 5, make sure there's no leak, and you feed them for a day, and then you send them home.
Okay. So the students are clear that the new esophagus is just using the parts that you've already had, the patient already had,
Yeah.
from the stomach and his esophagus, and you just pieced them together to create a new one.
Yeah, so what we did is we removed the 2/3 of the esophagus from the top and 1/3 of the stomach. And then we brought the stomach as a tube and connected to the remaining part of the esophagus. And now there was a wall between the two, and the circular stapler just cut the wall, created a hole between the two, so the food comes from top and goes into the stomach, and sealed the line circularly, to
Right.
cause the anastomosis, to create the anastomosis.
And so this patient now is eating normally?
Yeah, he went home and he had but there's a term we use, it's called complete pathological response. That means there was no cancer cell left in his esophagus.
So here's the question. It's kind of hard to visualize for the students, especially when you're seeing the surgery on the screen. It looks big, but you're operating all those instruments in a tiny little space.
Yeah, and that's the beauty of it, is because your hands are in the chest or abdomen, and the robotic instrument has 8 level of motions, same as or better than human wrist. So you're operating there without putting your hands in the chest. And these patients recover very well, and they recover very fast. The outcomes are better than open surgery. Imagine if you slash open somebody's chest, crack the ribs, put your hands in the chest, their recovery will be much harder as compared to you're not spreading the ribs, you're not breaking any ribs, you're making 4 small holes, that's it.
So one of the questions students sent in was, how does the robotic procedure compare to the traditional way that you used to have to do this surgery?
Yeah, so historically when you did esophagectomies, the mortality rate was 15% of these patients will never make it out of the hospital. Now the mortality is down to 1.4% or 1%. And this is not only just for robot, but minimally invasive surgery, better inpatient care makes a difference. But the traditional recovery will be very traumatic recovery, because you have to open the abdomen, cut the abdomen, you have to cut the chest, break the ribs to get into the chest cavity. So you don't make a big cut in the abdomen, so these patients don't develop hernias, or the bowel function returns very quicker because you're doing it minimally invasive. Same thing with the chest part, they can breathe better, it hurts less, so they don't develop pneumonia and other complications.
So from the time the patient was brought into the operating room until the time you were done and they were taken into recovery, about how long is that total procedure time?
So depend on the procedure. For esophagectomies, it takes 3.5 to 4 hours.
Okay.
Because you're doing the abdominal part, then you put a temporary feeding tube, which we did not show in this video, and then you do the chest part, and then anesthesia takes their time to put the patient to sleep and wake him up. So it easily takes 4 hours.
And then how long does the patient have recovery time after the procedure and after going home and everything?
So the patient stays in hospital for 5 days and go home on day 6 after esophagectomy, and then they need at least 2 to 3 weeks to recover.
Does does removing the pieces of the esophagus and the stomach, does that affect the patient?
Yeah, I mean, they cannot, they have to learn how to eat again. They cannot go in a restaurant and have a 3-course meal to start with. They eat small, frequent meals, because remember, the stomach is usually a bag. You can put 3-course meal into it, but when it's a small tube, you can eat a small portion and you will be full. And then you eat again in a couple of hours. It takes at least 3 to 4 months for the patients to feeling normal and eating regular food.
So that the stomach is a little bit smaller. And, yeah.
And then patients get used to it, what they can eat, what bothers them, and how much they can eat. They adjust their lifestyle. But they all lead a normal life.
And a question from Polka High School, what about reflux? Does this help with reflux, or does it?
This is a very good question, because it does cause more reflux, because the sphincter is gone now. So these patients do complain of some more reflux than usual, because there's no mechanical barrier anymore. You lay flat, but on the other end, you're making the stomach smaller, you're cutting the vagus nerve, there's less acid production. So most of the patients lead a normal life. But yeah, the certain number of patients will have more reflux and regurgitation. So if you eat a big meal and you go to lay flat, you will have a regurgitation.
So it's that they learn to live with the new system.
Sure. It's a bad disease to have. I mean, the survival is now, in current era, is much better, but used to be in the past, without chemotherapy and immunotherapy, used to be 25% of people will live long term. Now almost 60 to 70% will live long term.
And maybe just explain, in the video we saw you holding up the cancer parts, the pieces that you were cutting out, but explain to the students how you get that out of the body.
So we made one of the port site, we made it bigger, like 3 centimeter, and then we introduced a bag and put the specimen in the bag and pull it through that.
So everything, those are tiny cuts, and the ports go through there.
Yeah.
Your instruments go in, and anything that you bring out, cancer, anything that you've cut, all come out through those little tubes.
Yeah, one of them you enlarge depending on the size of the specimen, and then you put a bag in, make sure that the specimen is in the bag.
So Cameron High School, here's a question. During the procedure, how do you prevent the patient from involuntarily swallowing?
During the procedure, patient is under anesthesia. So they're paralyzed, they're under anesthesia.
We saw you work in there, and there was a lot of movement, especially in the chest. So you're near the heart, the lungs, up there.
So it's a very narrow space, and as I said, but if you do it multiple times and you get you good in the procedure, you know your planes. But yeah, if you're 1 millimeter here and there, sometimes you can get into the aorta, you can get into the windpipe, you can injure the heart. You have to be very careful with your movement, because if you do jerky moves, violent moves on the robot can break bones, the instrument can hurt the other organs, so you have to be careful.
And the robotic arms, they help you be more steady, more precise.
Yeah, the robot takes the tremor out. A lot of surgeons who have a mild tremor actually do okay with the robot, because the robot filtered the tremor out. But your movement has to be, you have to be an expert in the robot to do these complex surgeries, because when you do these tiny moves, and like if I'm doing this scissor in the body will be cutting. So if I do it very frequently, it will make a bigger cut. And how much you pull, there's no aptical sense. So you cannot sense how much you're pulling. That's the problem with the current robot. In next generation of robot, you may feel tension. Like if I'm pulling, I cannot tell how much I pull. You have to use your sixth sense by looking at the tissue, looking at the stretch, and then give you a clue that you're pulling too much or too little.
Yeah. What's the most common side effects or complications that happen with this type of surgery?
So most common or the major complication is an anastomotic leak. When you connect this, esophagus is a dangerous organ to operate on. When you connect the esophagus and stomach together in the chest, 5% of time they don't heal. So if there's a leak, that leads to infection and sepsis. That's why we have a drain in place. So if it leaks, then I go and put a stent in. And usually it's 5 to 6% anastomotic leak in the chest.
How long do you leave the drain in?
Till the day they go home.
Okay.
And then we sometimes send them home with the drain and then take it out in the office.
And I assume they come back in a couple of weeks for a checkup and make sure.
I see them in 10 days 7 to 10 days in the office, then in 3 weeks, and then every 6 months for 5 years, then every year for 5 years, a total of 10 years.
Yeah.
Yeah.
So that's a long journey for someone who
Yeah.
has esophageal cancer.
Cancer is unique because rest of the conditions you have, that's a disease. Cancer is a journey which affects the whole family, the whole loved ones, the whole circle get affected by the diagnosis of cancer. It's unique and it takes a lot of attention and it needs a lot of support.
So how many of these type of surgeries have you performed?
So esophagectomies are not very common. I've probably done close to 200 now. Out of probably over 15,000 operations, 200 have been esophagectomies.
Yeah. I think you've already answered this, but we have a question from Wyoming East. The metal tubing and everything that you were using there to connect and rebuild the esophagus, you took all of those pieces out.
So that's a stapler. So the stapler fired and you took it out.
And the other pieces that you were using to connect,
Yeah.
that all came back out. So
Yeah.
it's just the patient's normal pieces
Yeah.
of the esophagus.
There's no foreign body left.
Right.
The only thing we use a staple is to call mechanical suturing. So there is a two-way of suturing. One is you take a suture and a thread and you tie it. The other one is mechanical suturing, where a stapler uses a stainless steel staple. It can be a linear or it can be a circular. So we use the linear stapler to create the tube, and then we created the circular stapler to create our anastomosis.
So here's a question from Spring Valley High School. How much easier or harder does the robot make your job?
I think robot makes our job easier and most importantly makes the patient's outcome better.
How does it change your approach? Like for this surgery, how did you do it differently than you would have traditionally before the
So traditionally, if the robot was not available or minimally invasive surgery was not available, before the robot, we were doing it laparoscopically and thoracoscopically using cameras, same technique, but we were at the bedside. A robot gives us advantage of doing a better dissection and do more complex cases. We may not have not done it with the other minimally invasive modality like laparoscopy and thoracoscopy. The open traditional used to be that you make a big cut in the abdomen, lay the abdomen open, and then you go into the chest and you make a big cut between the ribs and cut one of the ribs and spread the ribs. So that's very traumatic to the human body. And there's a lot of complications associated with that large incisions. Healing is delayed, poor healing, more complications.
So we've come a long way from completely opening up the patient to doing it laparoscopically, but you would have to stand beside the patient with your hands doing the work, and now you've got the assistance of the robot making it more precise, and your view's a lot better.
View's better, and the laparoscopic instruments are like a stick, that is like long sticks. The robotic instrument has a wrist, so it has the same movement as a human wrist.
Is this the procedure that you did on this patient? Is this similar to a gastric bypass?
Gastric bypass is a simple procedure in a way, yes, that you cut the stomach there and you connect the small bowel. That's a much easier procedure, quicker procedures to do. This is more for a cancer. So you're removing the esophagus. In the gastric bypass, you're removing most of the stomach, or you're bypassing the most of the stomach. Here you're removing the esophagus. And then gastric bypass, the tissues are not attached to each other. This is cancer, everything was invading. The tissue is growing into the surrounding structure.
And with this patient, was he on a liquid diet or anything like that?
For a couple of days, yeah. So they stay in liquid diet for 3 to 4 days, then slowly build to soft diet, and then regular diet.
Okay, and so by now he should be back to
Oh, he's
whatever
not-
he can
yeah,
tolerate. Yeah,
He started having a regular diet, regular life.
great. Well, I don't see any other questions coming in at this moment, so I think we might be near the end. We'll continue to answer questions via Twitter for the students who are want to refresh their timeline on Twitter and throughout the day. So we'll keep an eye on that. But we'll go ahead and wrap this up and let you get back to more work.
Yeah, I just had a quick message for the students. I will say healthcare, anything you do in healthcare, you can be a biomedical engineering, you can be a medical assistant, OR tech, nurse practitioner, a doctor. It's a very rewarding career. Anything you do, it's like a sacred career path you're choosing, that you help people and you get respect and you get paid well.
Yeah.
So in my eyes, there's only few professions in the world you can go where you make such a huge difference. So I will encourage the students consider the healthcare as one of their preferred career paths.
But we're going to need health care all of our lives.
Yeah, absolutely.
And we need the young people to take care of us as we get older.
Definitely, sir.
Thank you so much, Dr. Abbas, for showing us the surgery, for allowing us to record it, and then definitely for being here to answer the questions from the students.
Thank you, Dal. I appreciate it. Thank you very much.
Thank you to the students and faculty who sent in all the questions to us. We really appreciate your participation. As I said before, keep following CAMC Health on Twitter and use the hashtag ImagineU. We'll answer the questions that we didn't get to during the webcast. And don't forget to complete your survey. Go to camcinstitute.org/ImagineU. That's very important because we use your comments to make our future programs even better. We're constantly looking for improvements, so please fill out the survey. Thank you for watching this webcast. ImagineU is a collaborative effort of the West Virginia Department of Education and Charleston Area Medical Center. And as we leave you, you'll see some of the names of the people who worked on today's webcast. Thank you and have a good rest of your day.